Whether you're joining us live or tuning in on demand, I am delighted to welcome you to today's discussion titled AI for Better Care, from Predictive Insights to Personalized Patient Journeys. Without further ado, I'd like to introduce you to Holly Say, who is the CEO and founder at Novella Insights, and who will be moderating today's discussion. Holly, the floor is yours.
All right, fantastic. Thank you so much, Josh. Hi, everybody. I'm Dr. Holly Say, a physician executive and founder of Novella Insights, and it's such a pleasure to be with you today. And I appreciate everybody taking time out of their busy lives as well to join this webinar. Little background about me, very quick. I've served as a hospital chief medical officer, have led large urgent care and primary care networks, and now advise healthcare organizations on clinical transformation and AI integration, while continuing to see patients and teach internal medicine residents. I'm focused on building what I call the clinic of the future, where technology enhances clinical judgment while keeping the patient at the center of care. To introduce today's topic, we'll be talking about AI not as a shiny object or a theoretical tool, but as an operational must-have. We'll focus on three themes: risk prediction to anticipate and prevent harms, personalization of the patient journey, and cultivation of trust. Prediction and personalization, of course, are two benefits we hope to gain from AI, but it can only move as fast as the speed of trust. So now let's meet our panel. We have an extraordinary group of leaders with us today, working in the overlapping domains of digital health, AI, clinical operations, and enterprise strategy. I'm going to give a short intro for each person and then ask them to say a couple sentences more about their bio and a couple sentences about a high-level question regarding their company. And we'll start with Maggie. So Maggie Helms is Senior Vice President and Chief Data, AI, and Digital Officer at Health Partners, where she leads enterprise AI strategy grounded in human-centered design, a topic that's dear to my heart, and I know other folks on the panel as well. So Maggie, please feel free to fill out your bio a little bit for us, and perhaps you could say a few sentences on how AI fits into Health Partners' overall strategy.
Absolutely. Thank you. I'd be happy to. And good morning, everyone. Maggie Helms, and I think the main thing to know about me, the most important thing is that I'm a huge nerd. And so I absolutely love programming. I love math. I love working with teams. And I'm very, very excited and energized by all of the potential that artificial intelligence offers in healthcare and many other spaces. And of course, any great opportunity comes with substantial risk. So, mindful of all of that. And maybe one other thing to share is that I am, for better or for worse, married to a physician, and I receive constantly in my personal life as well as professional life a lot of real life on the ground feedback about all of the things that go well and badly with major data, digital, and technology deployments. So I've really enjoyed working through this space with sort of an eye toward the front lines and an ear toward all of the joys and pains that sort of come with major innovations like the ones we'll be talking about today.
That's wonderful, Maggie. Thanks for sharing that. And you and I have the inverse. I'm a physician married to a health IT and data engineer. So I like to say we talk about the same stuff, but with very different lenses and language and learn from each other. So that's really wonderful. All right. Thank you. Okay. Dr. Mark Townsend serves as Chief Clinical Digital Ventures Officer at Bon Secours Mercy Health. He bridges clinical operations and strategic investment through Accrete Health Partners. And also, if I count this right, I believe he's quadruple board certified, which might be a record, in adult and pediatric cardiology. So Mark, please feel free to share any additional details and briefly tell us how central is AI to BSMH's digital strategy right now?
Yeah, thanks for that, Holly. And I think you're a MedPeds doc as well, right?
It's true.
Yes.
Guilty.
Well, so the persona of MedPeds is that you like to multitask, and it's often said you kind of go big or go home. And so I began my career as an academic cardiologist, had four kids in 4 years, and kind of go big or go home mantra. And that ended my academic career. So I did a pivot into healthcare delivery in not-for-profit, but also at the same time began an administrative career as an operator. As a medical director of operations was my first administrative role. Concurrently grew and built my own technology selfishly to serve my patient population of adult congenital cardiology. But yeah, so Bon Secours Mercy Health is spread predominantly over 4 states, 50 hospitals, 5 additional hospitals in Ireland. And we have a company called Accrete Health Partners that we use to do investing, strategic investing, and our problem statements of the health system source the investment thesis. And specific to AI, we had this conversation with our leadership team a couple of weeks ago, and there's a mandate and an edict of sorts, both were terms that were used to adopt AI. So we're working hard, fast, and furious, and it'll be a fun conversation today. Thanks, Holly.
Fantastic. Okay, thanks for sharing that. All right, we'll move on to Dr. Kip Lee, who leads UH Ventures, the innovation and commercialization arm of university hospitals. His background spans healthcare, design, and enterprise innovation, so he brings a systems and human-centered design lens to AI deployment. Kip, please tell us a little bit more about your background, and could you also describe in a few words how AI shows up in your enterprise innovation roadmap?
Yeah, nice to connect here, and uh, hello to everyone on the call joining us. I'm not from healthcare, and many on our team are not as well. So we can't help but, or it's necessary for us to work with our caregivers and clinicians, which we love doing. And when we approach a problem or a situation, I guess in contrast to Maggie, oftentimes we feel very dumb and humble, and as opposed to but we love to geek out. That's what I'm trying to say. So it's a great opportunity for those who are curious, and we're a small but mighty team, been in existence within university hospitals for a little over 10 years. And we're not the kind of warehouse that's 5 miles away with foosball tables, that kind of an innovation group. We're really embedded in the heartbeat of our campus, our main campus, in fact. Um, Prior to coming to university hospitals, I was the product architect for Marriott Mobile, now called Bonvoy. So I won't ask if those on the call like it or not, but to the extent that we can bring that hospitality customer experience ethos to our venturing work, innovation work, engagement work, I think that's where also human-centered design comes in. A segue on that point, our approach to AI at UH is a mashup of human-centered design with AI, calling it very explicitly human-centered AI. And we're seeing a number of schools, institutions, Stanford, Oxford, really embrace that term. And it's not just bringing that ethical lens in as a secondary thought, but bringing the human, not just the human in the loop, but really extending it beyond that, holistic approach. So we're inspired by other areas that are already doing this. What might it mean to do human-centered AI within healthcare? And so joining many of you on the call, really approaching that and pioneering that. Nice to be here. Thank you.
Wow, that was super inspiring. Thank you, Kip, for sharing that. I love the sort of exploration of human-centeredness there and customer service, like where you bring that from your background. I've often said that it's really helpful to have waitressed or waitered in the past when you go into a field like medicine, because there are really some parallels of just making people happy and how do you do that, obviously within reason, of course. Okay, thank you so much for that. Now, Justin Vincent is Senior Director of AI Technology at Elevance Health, where he leads clinical AI and innovation efforts to unlock predictive insights across the patient journey. He combines deep scientific rigor with machine learning production experience. Justin, could you share any other background information and tell us briefly how you are translating advanced machine learning models into real-world clinical value?
Yeah, well, thank you so much for the opportunity. Yeah, so we're very excited about the new developments in AI. Obviously, there's been a big wave of activity in the generative AI space, but there's sometimes folks will overlook some of the more traditional predictive modeling in the context of this big wave of generative AI, and I think it takes a little bit of both. AI has really become a fixture in healthcare, but despite a lot of the excitement, a lot of the innovation today, it's really incremental, right? And that transformative process of AI, it really lies in our ability to not merely refine, but to redesign how patients experience care, how care providers are delivering it, and how payers work with both to, enhance that healthcare journey, right? So, I mean, I'm previously came from AWS, and one of the leadership principles over there is on customer obsession, right? And I take that with me every day. With what I do is let's focus on the customer, in this case, the member, and keep them at the center of how we think about that overall transformation, because it's not just tech for tech. We want to focus on what experience we want to bring alive, and do that through AI. And we think that the organizations that are going to succeed over the next decade will be those that, not necessarily with the most algorithms or the most agents, but the clearest alignment between an AI capability and human connectedness and customer or member-centered outcomes, patient-centered outcomes. So thanks. Looking forward to um, this panel today.
Wonderful. Thank you so much, Justin. And you kind of stole my concluding line there. I love it. I might have to just drop the mic after what you said there about which organizations are going to succeed. So that's fantastic. And what a varied group that we have with us today with amazing background to dive into this discussion. So let's go ahead and kick things off. We're going to start with an overview question. At a high level, how is AI changing the way your organization thinks about managing patient risk and delivering care compared to even a few short years ago, maybe even just 2 years ago? And I think maybe Justin, you might have some thoughts about that.
Yeah, sure. So at Elevance, we have um, shifted from offering AI as like, kind of like a menu of capabilities to thinking more about personalization as an organizing principle. So, when we're predicting or mitigating health events, but also simplifying that experience for healthcare. And, on the scale of data that we are using, we've got a lot, health plans, clinical data, engagement data, social data, and that helps us to enable business critical insights for the company and deliver them consistently. And we've got a number of platforms, our Health OS platform for managing and organizing a lot of the data and also bringing those insights. Also, our AI platforms, we can, start to organize that longitudinal patient record, that member record, and share insights back to providers directly at the point of care. And explicitly here, we're thinking about AI as a means to assist humans, right? So we've got a lot of responsible AI guardrails in place for bias, accuracy, security, transparency. That's job zero. But then going and trying to enable humans in the loop there, right? So if you think a couple of years ago, a lot of organizations they were using machine learning to predict outcomes, and then they will utilize, let's say, a risk score to stratify that population for outreach, care management. I think now we're really focused on how do we operationalize these predictive signals into a real workflow? Who do we reach out to? When? What interventions do we use? And how do we do that with governance, monitoring, clinician trust, member trust, all built in so that we can drive actions, so that we can change outcomes ultimately, right? It's not high enough. It's not 2 years ago, if you had high accuracy, great area under the curve, well, great. That's fine, but that's not fine anymore. I think now the metric is much more aligned with the value. So did that model actually reduce avoidable utilization? Um, and so again, not a dashboard, but more used in conjunction with, let's say, generative AI capabilities to go end to end, sometimes even directly communicating with members or physicians and providers, care managers, bringing those real-time insights in and associating that with a lot of automation.
There's probably all the rest of our questions, some themes from the entire content of the webinar all together in one. That's really, really great. Let me just, before I ask a follow-up question, let me open this up to anybody else. Any other thoughts or comments about that? I love what you said about sort of taking theory and tools and actually making it real world that somebody who's doing the work can use and act on for better outcomes. Any other thoughts? If not, I'm going to ask a follow-up.
Can I take it a slightly different angle, but building on Justin, I think it still stays within the relevant question and topic, Holly.
Yeah.
Justin touched on governance, and I think you also, your opening line, Holly, was about You can only move at the speed of trust. And so, how
Right.
do we move rapidly at the same time engage all the right stakeholders? Stating a truism here, but making that come to life, it has been non-trivial. We've set up our governance structure, and I see some nods here, where our approach has been like a dual chamber governance approach where we have an AI council comprised of voluntary uh, caregivers from an assortment array of areas within the system, clinical, non-clinical, to adjudicate on Epic related opportunities. Epic is our EHR system, but also outside in opportunities that come our way. And getting that first look and that group to meet and deliberate on the safety issues, the quality issues. So we primarily look through the lens of risk mitigation, cybersecurity, and compliance. And then, of course, the ongoing debate, well, when does operations come in? When does the financial component come in? So we're still navigating and evolving that and iterating, but that first piece focused on risk mitigation, compliance, and cybersecurity has been really helpful to unify our team. And so that's let's call it the lower chamber. By lower, I don't mean, lower in hierarchy, but starting there and then
Foundational.
passing that on to our equivalent of the Senate. So we have an AI council and an AI oversight committee, and there's constant communication and flow there, and also making it very simple for our caregivers because we want to get to yes, if at all possible, as opposed to killing opportunities. So trying to do that in terms of a balancing act and building the capabilities has been very fruitful. And of course, learning from colleagues and peer institutions absolutely critical in exchanging ideas. So that has been a central feature and function of our evolution probably the past 2 years.
Amazing. So you're kind of talking about addressing issues of safety and compliance. Like, is this even okay to use? How are we going to make sure that we're not doing harm with this
Yes,
before you get into sort of maybe not details, but like different order functions of finances or clinical workflows or whatnot?
that's right. That's right.
Yeah, incredible. All right, well, let's circle back to that when we get into governance. I think that was a great sort of teaser or a taster. And you anticipated one of my questions, which was going to be if there's an oversight committee, who's on it, and how do we make sure that all the relevant voices are heard and things of that nature. Um, Fantastic. Thanks for jumping in there. So let's move on to sort of the one of the themes that I said that we would be focusing on today of risk prediction and how to use analytics to help us guide allocation of resources to prevent harms before they happen. So really this shift from reactive, looking at dashboards, looking at who was hospitalized last quarter or who cost the most last quarter to predicting who's going to cost the most in the next quarter, that kind of thing. So let me ask, how are you using AI to predict hospitalizations or ER visits before they happen? And what signals or data sources are the most valuable for that purpose? And maybe I'll toss it over to Maggie to speak first.
Yeah, thank you. And
Mhm.
I'm going to gesture back to something Justin mentioned in his opening. I think this is an area where we've found at least that some of the traditional machine learning models do continue to serve us pretty well. Um, but I'll caveat that. So I think there are some models that have been around and in great put to great use in healthcare for many, many years that still do a nice job predicting hospitalizations and emergency department visits, both necessary and unnecessary before they happen. Often these models are starved for good data, and I think it can be difficult to understand the why. So if someone is highly likely to use the emergency department, let's say unnecessarily, why? And what do you do about it? And that's where I think AI is helping us with a big leap here. So for our organization, artificial intelligence is helping us curate all of the data needed to hydrate those models more quickly, more accurately, and at scale. Wearable data, I'm sure everyone on the call can, relate. Wearable data can be difficult to integrate, difficult to get your hands on. This can be sort of expensive, large scale IT projects, so to speak. And now we can kind of integrate those data much more naturally into our electronic health records or whatever platform folks are using. I think the other thing is that why, just understanding, is an individual likely to have a visit because of a particular diagnostic profile, because of a particular behavioral pattern that, is noted in the data, that's where those large language models can really help with the next best action and what is the right intervention. Because knowing something is going to happen before it happens is helpful. It's much more helpful if you could do something about it. So I think that that's where we're seeing the big leap in AI.
Awesome. Here, here. Let's do something about it, right? So, yeah, you kind of have touched on a simple example that I give in my talks is like that heart failure patient who has a connected home scale. The scale detects that the weight is going up. This could be fluid retention that's going to be an ER visit. But actually, right, so that's a very cool use of a home connected device, not quite wearable, but, in that realm. But what about if we can also integrate pharmacy data and say, oh, the person missed refilling their diuretic medication? And then also notice that, oh, they've been sending more portal messages saying that they're short of breath or they're fatigued or legs are swelling. We also noticed they went to the ER not that long ago. And putting all these things together, I'm thinking that can give us a more refined prediction model. Is that the kind of thing that your organization, Maggie, or anybody else is doing, really pulling in data from all of those different types of places where they used to be siloed and now can be brought together?
Yes, absolutely. So just at a high level, I think we're finding great value in integrating claims data, clinical data, wearable device data, pharmacy data where appropriate, and not only data from a variety of sources, but understanding exactly how those data need to be staged in order to really add meaning in a specific context so that we can come up with sort of those more nuanced why-based models that kind of get at not only is this the outcome I'm predicting, but these are sort of the necessary data points that need to accompany the prediction in order to put it to good use.
hmm And can you comment or anybody else on how we get that in front of clinicians in real time, whether it's a nurse case manager who needs to call the patient and check in about why did you miss refilling your diuretic, or it's we need to have a video visit and talk about upping the diuretic dose before you hit the ER?
I can certainly share how we're doing it. I'd be curious to hear from others.
Yeah,
I suspect there may be a
great.
better way. We are still relying heavily on the registries and the workflows that we had in our electronic health record, really prior to
Mhm.
what I would call the AI boom. And that is, I think someone said it, but it's partially because our workflows haven't always necessarily caught up to where technology is today, nor should they be in a race to do so. We do need to have strong governance and a solid understanding of what we're doing before we do it, I think. But we have thus far in our organization still been relying on our pre-AI boom workflows and registries, and we've been coming up with clever ways to really sort of place AI generated insights into those pre-existing tools and mechanisms to minimize clinician disruption. There is a strong
Mhm.
appetite emerging from our clinicians to do this differently. I found that we are most successful when the clinicians are really inspiring and motivating a change in their workflow themselves versus it's being imposed on them by a technologist. So,
Right.
I guess.
Exactly. Kind of a lean in healthcare principle, right? The people doing the work who are actually closest to the production line, if you will, have the best insights on that. Yeah, awesome. All right, Justin, yes, please jump in.
Yeah, one thing that we've really leaned into over the years is something that we call Health OS. It's an interoperability platform. And so, brings in a lot of data aggregated through a clinical data exchange capability. And so we can pull data from connections to providers, leading EMRs, health information exchanges, our own claims data, and organize that and get that full view of the member's
Wow.
care history. But then the really powerful thing is that we can take derived insights and share them back to providers within their EMRs at the point of care. And so I think we have somewhere around like 30 million total members with this Health OS. Connection. We're connected to 120, at least 120 large health systems. We've got over 18,000 providers connected in all 50 states, and um, you know, um, tens of thousands of portal users through like our total member view, our longitudinal patient record, and this helps us to really directly plug in. At that point of care, which is useful because sometimes, the means to do to communicate something is not directly to the member. We want to go with their physician. We may not know.
Right.
Might not have all the facts. We need to kind of have that direct connection, and this is a way to make that seamless.
That's amazing. That's almost sounds like the holy grail of pulling all the information together and then trying to get it in front of the right people at the right time. As a practicing physician, I know that if that patient isn't on my schedule, if I get a message saying, oh, they're rising risk, currently in my organization, we don't have a great means of carving me out some time to reach out to them or send it to the nurse case manager or whatnot. So that's an important part of it too. We do have an audience question which says, is this open source, Health OS? No.
No, it's not.
Proprietary. No, it's not. Okay, sorry. All right, very good. Okay, well, this is awesome, you guys. Let us move on and ask about what specific chronic disease progression patterns can AI detect earlier than traditional approaches, and how much lead time does that give care teams? So, kind of actually related to what we said, but specifically focusing on some of these known chronic diseases that tend to flare and land members or patients in the ER. Mark, why don't you take that away?
Yeah, sure. And I love that you began this conversation with the emergency department. And Maggie, that's a great call out there specific to using machine learning. And I think, Justin, you brought up that point as well. We were trying to solve this right before the recent AI boom. But in that space, for example, some of our earlier experience was in the emergency department using sepsis detection. And we've all been through ESM, our sepsis models, and they had some upsides and some downsides. We've elaborated and built out cognitive assistance in that space for nurse triage with an external partnership. And that has informed the way we're looking at this now, specific to chronic disease management. I think our first wholesale go big, conversation with chronic disease management was again a partnership specific to CKD and a high risk population, obviously. So the insights that we developed from that really helped us then inform our own native approach, which was to use our own data resources, our data mart, build an analytics layer specific to our PHSO. And our Pop Health Services organization has roughly 60,000 patients under care management. So in that space, we use these tools now essentially to look at risk, and those tools have gotten increasingly sophisticated. And then, specific to marrying that up with the cost of care, recognize that heart failure specifically is our Pareto, if you will, that disproportionately consumes resources. So you can use NYHA classifications. I'm not saying this because I'm a cardiologist, but our teams did this
Sure.
independent of my input, right? But they developed these models specific to risk in heart failure and have really gone after that. We did a native homegrown approach through an extensivist model, whereby essentially a care navigator gets the information that a patient's risk is increasing. And you referenced some of that, Holly. There's some good background informative work that's been done in that space. But now, as we double down on that high risk population, we're also then going back to say, okay, well, let's look at the low risk population, right? And so if we're going to risk stratify and zoom way back out of heart failure and go to that 60,000 patient panel, then we're developing tools and need to develop tools specific to the low risk part of the population. That's really, I think, where the post chat GPT, the voice agents, the agentic agents become very meaningful. And so we're just beginning that journey. So it's a fun time to have that conversation.
That's awesome. I love that you brought up the Pareto rule, and it's so applicable to many things, right? You could say that you wear 20% of the clothes in your closet 80% of the time. In this case, it sounds like it's 20% of the patients causing 80% of the complexity or cost, and you're identifying heart failure as kind of a big category driving that. I think it's such a great common sense way to look at things. But also, when you talk about the low risk patients, is it focusing on low risk because everybody deserves care, right? Even if they're not that sick, everybody should have access to get their questions answered. And or is it identifying rising risk? So I think rising risk is this interesting category where we know the 80/20, we know those super sick 20% of people because they come into clinic all the time, or the ER staff knows them by name, but the rising risk patients who are moving from low risk up into that 20% category, is that what you're thinking as well?
Love that you called it out because the first time I had that conversation was actually with Justin's team, and that was like 15 years ago, where we were trying to predict the high risk, high spend populations before they happened, right? We've all been working on that for a long time. And that was with a different health system, had different partnership, but we recognized that we weren't very good at that time in doing that. We had a Medicare Advantage population and had a community health plan. So fast forward that conversation to today. Certainly, I think we're approaching it differently, obviously, with AI and the advances with AI. But I will say I don't think any of us have that perfectly figured out either. And I would say if we did, we'd all be using the same tool, and we would have driven down the total cost of care, right? And
Yes.
improve the lives of populations of patients. And that's not an excuse. I think that's just a pragmatic realization of, you know what, this
Yeah.
is it's a big picture issue. A lot of work that needs to be done in that space. And for you talk to our managed care team, they lose sleep about this at night because our risk bearing entities very much drive this conversation. So yeah, would Justin put you on the spot, but you guys are thinking you've
Good.
been industry leaders thinking through this for now a decade and a half. Want to talk about your most recent tools?
Yeah, so I love the tools. Just to be clear, I think it was what Maggie you were saying you were a nerd. Me too. And I love to get into the deep, into the details of, well, we could use this type of model, this type of architecture, all that. But really, it often comes down to the data, the quality of your data. Do you have that data point? I think earlier we were talking about wearables. That would be incredible if we were able to get that, right? But we're often looking for how can we expand out that data pool? Because if you've got the data, I mean, of course, a more fancy model will help, right? And it sure helps to have Gen AI to help us to extract insights. But at the end of the day, it's the fancy model will only take you so far. It's about having good, clean data, and by the way, having a lot of it, because
Mhm.
there's a lot of different trajectories that someone could go in, and the more that model, whatever your favorite flavor of model architecture is, the more that they can see, that model can see those different trajectories, it can help you build out a probabilistic future for that member. And once you have that, you can convert that into a decision. And I think that's where we are looking to go is to have that really robust data ingestion pipeline, a solid probabilistic future on one and many conditions, right? And then turn that into actionable insights so that we have an outcome that has changed because of this workflow, right?
Completely admire the work you're doing there. So thanks for leading the conversation.
Awesome. Thank you. And I think this is a good place actually for an audience question. Thanks to Darren for pointing this out, in that we have been sort of focused on outpatient population health and trying to keep patients out of expensive healthcare outcomes like an ED or visit or hospitalization. Darren asks, what's being done with available data to accelerate and inform patient throughput? So, hospital stays. Too often, decisions regarding discharge and ICU transfer are made by subjective decision by bedside teams. So true. We now have enough data that we should use that to inform patient improvement and readiness for discharge, ICU transfer to accelerate throughput. Can anyone comment on inpatient sources of data and how to collate that to make best decisions?
I'll jump on that because we've been working on that for a long time. And if you think of length of stay initiatives, like to say that we've been working on those since the advent of sliced white bread. And we have used multiple different technologies in the space, of partnerships in the space. Some that we've gone well down the path with, and then backed out, and then revisited, and the technology in that space continues to evolve very quickly. I would say our journey was to say that it needs to be fully integrated into the workspace of the physicians and the clinicians. It can't be an external interface that you have to go and reference. It has to be integrated within the workflow, so it's not this annoying BPA construct, disrupting my workflow. It needs to be embedded into my workflow. And to the extent that care management needs to
All
be,
right, just define BPA there for our audience. It's not
yeah,
clinical.
I'm sorry. There are these really annoying pop-ups. They're called best practice advisors, and they are
Yes.
perhaps mortal enemy of the acute care clinician, or the clinician who's really trying to get their work done. And next thing you've got two more
Yes.
clicks, right, to interact with some advice, right, which is unsolicited
Right.
in many cases. But yeah, no.
And
So
breaks your workflow as you're trying to get a different goal done.
exactly, right.
Yeah.
Completely unobservant of the fact that there may be some urgency or emergency to the care that you're delivering. So,
Right.
if that is where we don't want to be, where we do want to be is, yes, absolutely. Great question, because many of these tools can be built into the workflow so that it essentially elevates the work of our clinicians and becomes part of their daily thought process and pattern, whereby they rely on the information that will prompt them. There's an order that's missing for a patient who had a stroke and they're going to need an MRI before discharge, for example. By the way, you may want help, and now you've teed that order up and it's all ready to go, right? That type of stuff is where the technology is leading us.
Yeah, amazing. Well, I'm going to hit one more audience question here before we switch gears a tiny bit to make sure we're covering all our areas. And Greg asks about federated AI learning. So I'm hoping that the self-described geeks and nerds on the call will have input on this. And the question is in two parts. The first part is anyone using AI federated learning to pull data from various systems to get a holistic picture of patient health? And follow up, federated AI learning is to gather and clean data from multiple sources.
I would be happy to comment on that. I think federated AI learning and really federated development is probably the future. We are experimenting with it. I suspect many of the others on the call are as well. There are some challenges maybe that I can comment on that we're encountering early on. We talked about trust and how critical trust is. And I think we've collectively agreed on the importance of data. When we're federating not only the collection and curation of data, but the development of agents, and those agents, for folks who aren't, necessarily quite as technical, usually it's just sort of a fancy term for a small piece of software that is meant to help with a given task. And it's developed differently than traditional software, but it's still technology that's serving a purpose. When we federate too much, we disagree with ourselves. And I think that's part of the challenge that we're seeing is you erode trust quite quickly when you are collecting or curating, harvesting data from multiple sources, and those data points contradict one another. And you add a layer of obfuscation on top, if then you're also creating programmatic ways of leveraging that data that might bump into one another. So federated artificial intelligence is almost undeniably the future. And yet, the ability to orchestrate at scale is an imperative if we don't want to lose trust. And to me, that is where the challenge is. And to harken back to an excellent point that was made earlier, I I don't think anyone has figured that out. I think if we'd figured that out, we would be having a much different conversation today. But it's an exciting challenge, and I think it's one we're all up to.
Awesome. Thank you so much, Maggie. You heard it here first. Federated AI is almost certainly the future. I think I got that more or less verbatim. Okay, fantastic. We could clearly talk so much longer about every single one of these questions, but we're going to pivot a little bit to our second major theme, personalization. Okay, so of course, prediction is powerful, but if we predict without personalizing, we risk making the whole system feel mechanistic, possibly even heartless, kind of like the worst of lean in healthcare, like likening the patient to an assembly line or the auto industry or the car industry, et cetera. Although there's so many good parts about that parallel too. But let's talk about personalization. And I'm going to shift to Kip here. What role does AI play in customizing patient outreach, education, or engagement? And how does personalization improve adherence rates? And we did have a question in the chat about how do we know that any of this is helping or leading to better outcomes? So that's a ginormous question, but I'll throw it to you, Kip, to
Oh,
help lead us through.
it's worthy of a new section start based on the way you framed it. Well, we've been
Yes.
working with one of our close partners to tap into the way agents, as Maggie just pointed out, very small but very nimble software could do the work that our pharmacists aren't currently able to do. And what was great about this area of our system was our pharmacists had no issue with an AI agent coming in to support and supplement. As they self-admittedly said, we're great pharmacists. We're not good at outreach and making calls all day long to connect with our patients in the community, whom we would like to offer to come back or to connect with us for medication delivery. And sometimes they have gone to another place, a retail pharmacy, and the outreach is not trivial, as I think we all know. So using that use case, we used an agent with our partner, reached out, I think touched about 9 to 10,000 lives, and a subset of that, about 120 actually quotes converted to our pharmacy or converted back to our pharmacy. We had about 700 medications actually moved in the process. And so that duration was about 140 days. And what was great about that was just how personalized that was. And sometimes when you're making calls all day long, we know from Frederick Taylor, if we want to geek out on just management, scientific management as a theory, right? How just that rote
Mhm.
laundry process can be so
Yeah.
burdensome for our caregivers. So they said, you know what, if there's additional help we can do through this technology, and in some cases when we need to elevate it to human beings, that's where the controls and the oversight still remained intact. And it was comparable for about very small cost of $10,000, I think, to run this experiment. The ROI, the capture of the pharmacy was, I think, 3x. So notable, didn't require too much human effort, and a great way to complement existing needs, problems within the system. And of course, the benefit of all this is very friendly, not groggy, not bringing personal issues, as sometimes the case. I'll be the first to raise my hand. I just dropped off my kids this morning, and it's just a flustering experience, trying to keep my team members and others, out of that. But the AI can do that if done well. So I think a very promising use case of personalizing, and also in this case, generating revenue and touching lives as well. The good news is in cases where we were not able to convert our patients or the patients in the community, say back to UH, even then we got some data as we're talking about how important
Right.
it is.
Learn something.
Even taking your medications, even if it's not with us. And that was a data
Mhm.
point that we were able to collect and note as well, so that in the case where we can get to a federated AI model to share this with other health systems in the community who may be serving the same group of patients, do we even know this population is adhering to their medication?
Mhm. Oh, that's amazing. Yeah. Well, what a cool story, sort of bringing in the ROI on it. Also noting that, yeah, that voice agent never gets tired, never gets frustrated, never has to deal with its kids, right? I was chuckling when you were talking about, because sometimes it almost feels like the kids are the team members, in the business of the family.
Right.
Um,
That's right.
Anyway, but yeah, no, that's fantastic. And I want to ask actually some follow-up questions to yourself and Maggie and anyone on the call about how do we get to know the patients as customers? How do we segment them? Which, in my probably much more superficial knowledge of human-centered design than those of you who have degrees in it, is an important part of understanding which customer segments want to be communicated to in which ways. So, who likes the text message? Who likes the really long phone call with the empathetic AI agent? Who picks up the phone and who never answers the phone? How do you go about figuring out who your patients are as people so you can best tailor that outreach?
Can start jumping in.
Oh, perfect.
I think we have a point of view that you ask them, and what AI is letting us do is that we never could before at scale. Ideally, you'd
Right.
like to be able to have all of the time in your day to have a one-on-one conversation with every person you serve about what's best for you.
Yes.
How should we get in contact? Do
Right.
you prefer more or less information about this topic? Any number of things. And our poor clinicians certainly don't have time to do that with all of the many things we ask them to do in a very short period of time. And nor can
Right.
any of the health systems I've worked with afford to have, small armies of people who can really leverage that sort of like personalized nuance understanding of everyone we serve. Artificial intelligence doesn't tire, as we've just talked about. So it does allow us that ability to scale. So as long as we're smart about what pieces of information would a person be willing to share and or what feels like a non-intrusive question that might help us to serve you better. If we can offer that question, collect the answer. And then I think the real key that we've learned the hard way is, and then you have to honor that preference throughout the entire journey, not just one small section of it. Then I think you can make a real meaningful difference. And for us, it does just come back to the very simple. If we ask folks what they like, um, typically they'll tell us. And then if we ask them pretty regularly, how are we doing? Did we get this right? Was this good?
Right? Was this good?
That's a good way of
That's a
knowing
good way
whether
of
we've
knowing whether we
succeeded or not.
succeeded or not.
That's amazing. And yeah, how do you then sort of set those settings, if you will, all over their chart? Of course, we have these very crude things like preferred name, phonetic pronunciation, so that hopefully you say it correctly as you walk in the room type of thing. I imagine that's just the tip of the iceberg in what you're talking about of creating a customized profile.
It is. If others have found a perfect way of doing this, please let me know. We work really hard with our partners at Epic to make sure that we have good feedback loops back into our electronic health record, and it is very difficult work.
Right. Absolutely. No, thank you for sharing that. Is anybody getting into even things like voice agents in other languages or voice agents in regional accents that the patients may prefer? In English, that is.
We do have a very good
Marcus,
use case
there. Yeah.
for that. We have an emerging market in the Philippines, and that connectivity, for example, between like rural Virginia, rural Ohio, and the Philippines, has absolutely presented it as a use case that's very meaningful. So we're well down the path of trying to figure that out. We haven't perfected it, but the technology is there.
That's awesome. I have to ask a nerdy question. What about A/B testing? Does anybody run any A/B tests of, this message versus that message and see how the population responds?
We do. Our digital portal uses a method called Thompson sampling, if there's any other nerds on the call, to A/B test really every message we send, everything from if there's a subject line or a tickler that you would first see on your cell phone, for example, to then the expanded text. And we can A/B test by asking again, did you like this? Was this helpful? And then also the outcome,
Cool.
if we're asking you to, complete an action or encouraging you to take your medicines on time, are you? So that I think that has served us well with respect to really translation. That's also our approach is to collect that feedback because we don't have infinite translators, and we're a little shy to try voice translation like in an audio agentic experience, but we are trying to use artificial intelligence to translate some of our written patient education materials. And I think then the best way to know if we're doing well is to A/B test on a small scale with users who have sort of opted into that experience, and ideally are
Cool.
bilingual to tell us how do we do?
Right.
Was this right? Was this helpful?
Right. And your staff too. You may have a huge pool of people. I'm sure you're tapping them, the bilingual folks and whatnot. Yeah. Well, guys, again, we could talk so much more about this, and there's some great questions in the chat, but I want to make sure that we get to implementation and trust and governance. Kip started to mention that at the beginning, and there are questions in the chat about how do we build trust? How do we get physicians to adopt? Dawn called that out for Dr. Townsend, physician adoption and or resistance. So let's pivot to that. What data governance practices are essential for deploying AI in this way? And let's think about HIPAA, FDA, payer compliance, or other. And then we'll talk about building trust amongst our own people and the patients. Mark, would you like to start with that?
Yeah, sure. I think from a design perspective, and Kip nicely kind of prepped this part of the conversation relative to governance. We've systematically had a deep dive into governance, and a couple themes have emerged. So specific to the clinical adoption of AI, or said differently, the adoption of AI into clinical workflows, we have just very simplistically said 100% of the time, the clinician, the physician, the APC, the nurse has to assume responsibility for that documentation. From a governance perspective, every physician essentially receives care from the health system, has already signed a consent to essentially and a recognition that AI may be used in some form or fashion. But the clinicians then call that out as well. And the the first example that we implemented at scale, as most health systems did as well, was ambient physician documentation, which is
Sure.
ambient physician documentation was used, in the generation of this clinical note, right? And there's a dot phrase or a macro that is pulled into the documentation. So the human in the loop, I kind of say it ad nauseum, but the human in the loop has to assume the responsibility 100% of the time, for the work of the agent. Um, and specific to the adoption, particularly of physicians and clinicians, love that question because you need to measure it, right? And we have a slide, and it's embedded in our AI talks that we use internally, but it says success is measured in terms of adoption. So said differently, we can conceptualize these tools, roll them out, and they just are not useful, right? And so if they're not adopted, then that's the answer. Try to live a day without your device, your smartphone. It doesn't go well, right? So you use that as an analogy. I mean, it is the adoption that drives these curves. But if we're not asking and if we're not measuring adoption, I think then we're dropping the ball right at the inception of the conversation, and then from there it gets much more complex relative to measuring ROI and the business case and so on. But adoption is a great place to start.
Right. Yeah, absolutely. And yeah, I mean, I'm thinking back to the days of human scribes, which I was lucky enough to work with a few years ago. Kind of same thing. You would try to train them in how you like to write your note, but you remain responsible for what's in the note ultimately. I do think when we start to talk about clinical decision support, there's deep questions about liability. And, if AI feeds you some wrong clinical information, are you as the physician, if you didn't have time to check that and you acted upon it, where does the liability lie? So I'll just let that hang there. Maybe also you can comment on how we can make AI predictions actionable for clinicians and get them to trust what we're asking them to do.
I would, yeah, I would love to comment on that and maybe to build on, what we've been talking about with a specific example. So I'm not sure if others on the call are familiar with the tool Open Evidence. It's sort of a fan favorite in our practice, and it's one that we encourage the use of. And whether we're talking about the use of that tool or a different application that might be used at point of care, I think one of the imperatives is to give clinicians, pharmacists, and other anyone practicing who might be an expert in an area a clear feedback loop. Just this morning, we had an example of a clinical pharmacist who was using open evidence and found that it gave incorrect information, a pretty egregious hallucination about Y-site compatibility between ketamine and hydromorphone. That I'm told, I'm not a clinician, but we sort
Right.
of quickly rallied a team that could be a fatal error if the individual had acted on that advice. We do a ton of sensitivity testing. Open evidence almost never makes those sorts of mistakes, but it does. And so I think for clinician trust, understanding that we have a practice where you can provide that feedback, we do have sort of a rapid
Wonderful.
response and re-education program, helps our subject matter experts to understand that we take this seriously and acknowledge the very real truth that artificial intelligence is not infallible, and we need to continue echoing that back throughout our practice.
Yeah. Well, I love that admission. And also, we are not infallible. And we might read something in up to date, maybe not for pharmacy, but as physicians or clinicians, where it's so dense and it's so complicated and it's probably correct, but you might interpret it wrongly under pressure, and, do the wrong thing. So we're certainly not comparing to perfection, but it's like self-driving cars, right? You want it to be perfect, even though human drivers are not perfect, and we all kind of know about that paradox. But what I kind of got from what you said as well is that you're trying to show clinicians that they're not alone, right? They're not alone in these deep waters that all of a sudden have appeared with great speed all around us. And we're all kind of trying to swim and hold on to whatever life raft we can in terms of these clinical tools. You're saying we're here with you to figure out the fallibilities of the tools and help make it better. Yeah, I love that. Anybody else want to comment on building trust, whether it be with patients? Mark, you kind of mentioned that it's in the terms and conditions, so patients have implicitly consented, although we all know they don't always read that stuff terribly carefully, nor do I as a patient always. But building trust amongst patients, building trust amongst clinicians that, like Maggie said, or like Maggie was implying, you're not alone in this. What other best practices have you guys developed?
I want to thank you for that. I want to build on something Kip said, which is, specific to the use case of medications or, pharmacy
Mhm.
utilization. We are screening for social and behavioral determinants of health, as many health systems are. And I think we touched on it without really calling this out. SDOH screening absolutely is kind of that trust verification construct, which is you ask, do you have a transportation limitation? Then do you leave that hanging, or do you actually do something about it? So then that has prompted a relationship for and a partnership specific to how to address transportation limitations, or specific to the medication a question. I mean, how do I do medication adherence if I actually can't get to the pharmacy and get it picked up? And then so that turns into a meds to beds conversation, with our Harness Health, retail pharmacy, and so I think that is the credibility of trust in action. It's one thing to ask whether or not you have food insecurity, and then do we just leave you hungry, right? Or do we actually now try to address that? So,
Yes.
it's a credibility that is built. It very much becomes part of the relationship and the persona of our health system. And AI absolutely is enhancing that workflow. It is making it easier to really get to the right patient at the right point of care specific to their pain points and their needs.
Awesome. Yeah, you're really pointing out something I learned earlier in my career, that nothing makes people angrier than asking them for information and then not acting on it, or the next person asking the same information, getting back to that creation of the patient profile. Well,
Yeah.
we are coming right up on time. Josh, do we have time for a couple questions, or do we just need to wrap up here?
I'd say we've got time for one more.
One more question. Okay. So, guys, thank you for sharing your questions in the chat. Such great questions, and I tried to weave them in where applicable. I'm going to pull out a three-part question and try to squish it into one, which is how do you vet your AI vendors? Are you concerned about the large EMR platforms creating competing products that reduce your availability to provide, or your ability to provide meaningful value? And is your AI methodology tied to any specific vendor from a monitoring perspective, or are you using it strictly as a standalone on the clinical level? Three-part question, guys. Go for it. Sorry about that.
Concern, concern,
Mark.
concern. Yes, yes, yes. Kip,
Okay.
you've got to jump in.
Well, I'll try to be brief. We try to have a little fun. I think it's also important for us to, remain engaged. Uh, all of us on the call. We use a SPICE model, and that stands for a number of things. Uh, is it strategic? Is it is there something already pre in the system, a technology that we can leverage as opposed to onboarding something new? I, is it
Mhm.
interesting for our caregivers? C, is there a clinical champion? And then E, as a team, can we get excited about it to go from, soup to nuts in terms of shepherding or playing the Sherpa role? We
I
apply
love
that to
that.
all of our different opportunities, and I think it's not that different for AI. Well, actually, for AI, we add another one just for fun called Stratify, but why don't we leave that as a cliffhanger for those who want to
Cliffhanger.
continue the conversation. One more comment. I feel like we need to end with Pareto just because we wove him in. For the Uber
Good.
nerds on the call, the other thing I think he's known for is the theory of elites, where he talks about foxes and lions. And all too often, I think many talked about this. Mark, you talked about this, touched on this. We will start with something, and the foxes, we have to move around and be agile, very quick to onboard and pilot something. But he says something in his writing that's really provocative. He says, there are times when the foxes need to be lions. And how do we think about the system scale, institutional adoption of this? And so, as we're doing innovation work, how do you transition and play that dual role of being a fox and a lion? So, I'll give credit to Pareto, and we think about that balance a lot.
That's wonderful. That's better than any summary I had prepared for this. So I think we'll end it on time and hopefully under budget, right at 10 o'clock Pacific time, that is. And thank you so much to all the panelists and to Josh and to Thomson Reuters. And Josh, I don't know if you have any final words to close us out. Thank you, everybody.
Just to say thank you to all our panelists today, and to yourself, Ollie, for being such a wonderful facilitator of this conversation. But yes, Mark, Maggie, Kip, Justin, thank you all for joining us, for sharing your insights. And for everyone joining us, either on demand or live, if this is a topic you want to dive further into, you want to learn more about, please do look out for more info on Reuters Events Digital Health 2026, which is a live conference in Chicago this May 20th and 21st. We'll be joined by Holly there, as well as Maggie. And obviously, Kip and Mark, you'd be more than welcome to join us if you'd like to come down, as well as 300 of the most senior leaders from the top payer and provider organizations across US healthcare. So look out for more details on that. But otherwise, I hope you all enjoyed the discussion today. Thank you again to our panelists and to our lovely moderator, and we'll see you all very soon.